Good morning, ladies and gentlemen. In this lecture, I will introduce to you the concept of ocular surface. What is it? What is its significance in our daily lives? How it can be assessed clinically and how it can be affected by disease. Nowadays, a lot of work has been done on ocular surface, and it's because this is the most important part of an eye. The purpose of having a pair of eyes on the front of our face is to perceive a clear image of the objects around us at all times of the day or night and under all kinds of environmental conditions. The cornea must remain absolutely clear with a smooth polished surface to transmit light onto the retina without any undue aberration. So, to achieve this function, the cornea needs the help of surrounding structures, and all these structures work together as a single functional unit, which is termed the ocular surface. The concept of ocular surface was introduced in 1978 by Toft. It is basically the exposed outer surface of an eye that comprises of the cornea, conjunctiva with the overlying tear film, and all of which share some unique properties. In order to have a perfect tear film, the eyelids with the constituent meibomian glands, glands of Moll and Zeiss, the hair follicles, the lacrimal glands, and the lacrimal drainage system all are mandatory. So, all these six components operate as a single integrated functional unit, which is termed the ocular surface. All these six components are not only interconnected through a continuous epithelium, but they share the same vascular, nervous, immune, and hormonal control systems for their proper functioning. If one of these structures is not functioning properly, it affects the functioning of all other components as well, and the whole ocular surface is gradually compromised. The cornea and the conjunctiva constitute an epithelial surface that is most exposed to the environment. Our skin is also exposed to the environment all the time, but it is covered by a thick layer of keratin, and that keratin prevents the evaporation of water which is in the inside of the skin epithelium and in the epidermis and the dermis. But unfortunately, over the cornea and the conjunctiva, there is no keratin. And this is because to keep the cornea clear. But because of the lack of keratin, the uh, epithelium being exposed to extremes of temperature all the time can rapidly become dry if it had not been because of the tear film and the eyelids, which are there to protect both these structures against all potential pathogens like bacteria, viruses, fungi, or pollutants like dust, smoke, foreign bodies, irritant vapors, allergens, and environmental extremes of dryness and temperature. Therefore, all these factors need to be kept in mind as the underlying causative mechanisms producing disease and in any of these six structures. Additionally, due to the close proximity of the nasal mucosa and the nasal sinuses, the diseases that affect these structures can also spread and involve the ocular surface. So, the disease spectrum is enormous, So when you come across a patient which comes to you with a red irritable eye, watery eye, or problems with blinking or blepharospasm, you have to assess all these structures in addition to the nasal sinuses and the nasal mucosa. So the next important question is, why is moisture needed over the cornea? An eye has a total refractive power of 60 to 64 diopters, out of which two-thirds, that is 40 to 44 diopters, is provided by the cornea, while the remaining one-third, that is up to 20 diopters, is provided by the crystalline lens of the eye. The optical system of an eye is designed such that the cornea functions as a convex mirror, while the crystalline lens is biconvex. When light falls onto the eye, it first is refracted by the tear film, as tear film is the first surface that provides the uh, refracting surface for the eye, and then it falls on the cornea, which refracts it and converges it, and then further convergence of light rays is achieved by the biconvex lens, so that a clear image is formed on the retina. So to achieve this important function, cornea has to remain perfectly clear, avascular, and a transparent structure with a smooth, polished surface. The cornea maintains its clarity and transparency because of its unique histological structure of all its component layers, namely the epithelium, the Bowman's layer, the stroma, and the epithelium. The epithelium and the endothelium form important cell barriers that resist the diffusion of solutes and fluid flow across the cornea from the surface as well as from the aqueous, and maintain the clarity and transparency of the cornea. So, to act as a perfect refracting and reflecting surface, the cornea has to remain clear and transparent, and its transparency is by virtue of being a totally hydrophobic structure, that is, it repels all kinds of invasion by fluids. It's totally hydrophobic. The corneal epithelium is non-keratinized, stratified squamous epithelium. It's the external surface of the most superficial squamous cells are surrounded by a continuous band of apical zona occludens, as well as the tight junctions at their peripheral intercellular margins, which form a high resistance barrier to the external environment. So neither the fluid nor any kinds of bugs can enter into the corneal surface epithelium. Then beneath this apical layer are 2 to 3 layers of flat polygonal cells which are joined together by tight junctional complexes which are called the desmosomes. Both the zonula occludens and the desmosomes make the corneal surface hydrophobic, that is, water repellent, and it prevents any fluid from entering either the epithelium or the stroma. Thus, the water-soluble dyes like fluorescein or rose bengal are repelled, and they fail to stain a healthy corneal surface epithelium. Now, there is another particular and unique feature of the corneal surface epithelium is that the cell membranes of the surface epithelial cells have extensive apical microvilli and microplicae that help increase the surface area of contact and adherence between the tear film and the cornea. The microvilli are covered by a fine, closely opposed, charged glycocalyceal layer. Glycocalyx is a protein layer which is secreted by the surface epithelial cells. That glycocalyx coats the microvilli. Since they are charged particles, the mucin, which is secreted by the conjunctival goblet cells, is also charged. So the negatively and the positively charged mucin and the glycocalyx proteins, they attract each other, and the mucin coats the surface of the glycocalyx. The mucin in this figure is shown by the green color, and the microvilli and the glycocalyx are shown uh, by the yellow. So the mucin and glycocalyx complex, it makes the corneal surface hydrophilic, over which the aqueous layer can stay in, the aqueous layer of the tear film can stabilize. Without this mucin, the aqueous component of the tear film cannot spread over the corneal surface. Similarly, any lubricant eye drops that are instilled into the eye will fail to make the cornea wet in the absence of surface mucin glycocalyx complex. So the next important question is, where does this moisture comes from to cover the surface of the cornea? So the lacrimal glands and the accessory lacrimal glands in the eye, they produce the liquid component of the tear film, that is the aqueous, or known as the tears. So that those tears that are produced by the lacrimal glands, they are directed towards by the lacrimal duct to the lateral canthus of the eye. They gather in the lateral canthus, and because the lateral canthus is about 2 millimeter higher than the medial canthus, so they, by the virtue of gravity, they flow along the lower lid margin, provided the lower lid margin is tightly opposed to the globe. So in the process of this movement from the lateral canthus towards the medial canthus, the tears form a meniscus all along the upper and the lower lid margins. Uh, the additional tears, they gather in the conjunctival sacs. The menisci account for 75 to 90% of the total tear volume on the ocular surface, and their absence or reduced radius of curvature is closely associated with dry eyes. So when you're assessing for the dry eyes, it's important to look at the thickness of the meniscus along the lower lid margin. Now, how does tears spread from the lower meniscus onto the surface of the cornea? And this happens because by the process of the blinking mechanism. As the upper lid moves downwards towards the lower lid as a part of an eye blink, it the upper lid closes onto the lower lid from the lateral towards the medial canthus, like in the form of a zipper. And this zipper action, it creates a vacuum in the space between the globe and the closed eyelids. And then when the at the end of the blink, where as the eyelid is separating from the lower lid. It carries the tear meniscus upwards and spreads it uniformly over the whole corneal surface, provided the corneal surface has already been rendered hydrophilic by the combination of mucin glycocalyx complex. So the aqueous in the tear film can rapidly evaporate if it wasn't for the presence of the lipid layer over the aqueous layer. And this lipid, which comes from the meibomian glands, it covers the aqueous layer and prevents the thinning of the aqueous layer and of the tear film as a whole in between the blinks when it is again spread uniformly over the cornea. So in between blinks, the tear film has to be maintained over the cornea. However, if a person is staring at a screen for a long time and forgets to blink for more than 8 to 10 seconds or even 15 seconds, the person is standing in an extremely hot, dry environment, or there is a fan blowing directly over the in front of his face, and it forgets to blink, then the excess evaporation of the aqueous occurs in between blinks. As the aqueous layer reduces, the a dry spot forms on the cornea, and that dry spot can incite ocular surface inflammation, because as the amount of aqueous reduces in the tear film, the solutes or the salts that are present in the tears, they become concentrated. They make the tear film hyperosmolar. That increased osmolarity of the reduced or the remaining tear film, that incites a chemical reaction and chemical inflammation. The cornea is richly supplied by nerves. In fact, cornea is the richest has the richest nerve supply than the rest of the body. There are 2 million nerve endings, non-myelinated nerves in the cornea, which are present as an intrastromal nerves and as a subbasal nerve endings. Because of this extremely rich nerve supply, the cornea becomes a very sensitive structure, and this serves as a very important protective function for the cornea. As soon as a harmful agent lands on the cornea, it initiates severe pain, and this severe pain then results in outpouring of tears, and those tears then wash off the noxious agent out of the eye. So that brings us to the concept of the lacrimal functional unit. The lacrimal functional unit controls the secretion of all the three components of the tear film, that is the mucin from the goblet cells of the conjunctiva and cornea, the aqueous production from the lacrimal and the accessory lacrimal glands, and the meibomian gland secretion or the meibum that provides the lipid layer of the tear film. So as I mentioned earlier, as in between blinks, if a dry spot in the appears on the cornea or the conjunctiva because of excessive evaporation of the aqueous component, the hyperosmolar tear film that initiates a chemical reaction and or a chemical inflammation with the release of chemokines and cytokines, which stimulate the corneal nerve endings over the cornea as well as the conjunctiva, and they send impulses to the brain and via the secretomotor nerves to the lacrimal gland, accessory lacrimal glands, and the meibomian glands. There is outpouring of aqueous and meibum, and that replenishes the tear film. So if there is some problem with the sensitivity of cornea, if there are damaged corneal nerve endings, that happens as a part of disease or surgery, then the functioning of the lacrimal functional unit is impaired, and this results in an intractable dry eyes. So this slide just shows why is moisture so important over the ocular surface. If in between blinks or if the cornea is exposed all the time and there is a lack of tear film, or there is deficiency of aqueous or meibum or the mucins, then the cornea becomes hydrophobic. That hydrophobic cornea is dried up, it becomes lusterless, and epithelial defects or cracks appears on the corneal surface. The whole eye becomes irritable, inflamed, red, and it loses its function. The cornea no longer behaves as a perfect refracting surface. It and it becomes a dull mirror instead of a smooth polished surface. And since the cornea becomes hydrophobic, even the lubricants which are instilled into the eye will not be able to stay and make this cornea wet. So this tells you how important the tear film is to maintain the normal functioning of an eye. Such an eye in the absence of the tear film is like the extremely dried earth which is seen in areas where there are droughts and there is absence of rainfall, and hardly any vegetation is seen in that picture, with extremely dried patches of earth in which it's split up. Now let's discuss the three layers of the tear film, how the secretions are produced, and what are their significance. So the lipid layer is produced as a part of the meibomian gland secretion. Meibomian glands are sebaceous glands which are present in both the upper and the lower lids, about 25 in the upper lid and about 15 in the lower lid. They secrete meibum, and the significance of meibum in the tear film cannot be overstressed. The normal meibum is made up of waxy esters with very long chains of saturated hydrocarbons, sterols, cholesterol, and fatty acids that remain liquid at normal body temperature. So the normal meibum secretion is clear, oily droplets which can be seen over the meibomian gland orifices at the gray line. So these lipids, they cover the whole surface of the tear film and delay its evaporation, thus preventing the conjunctiva and the cornea from drying up in between blinks. Another important function of meibum is to coat the surface of the lid margins, particularly lining the undersurface of the upper lid, and makes its gliding movement smooth over the cornea by acting as a lubricant between the two epithelial surfaces. Meibum that coats the lower lid margin prevents the overflow or spilling of tears over the lid margin onto the lower lid skin, and prevents the wetting of the skin or damage to the lower lid skin surface. Meibomian gland secretion is under the influence of androgen hormones, which are produced in the body in minor amounts in women, but in large amounts in men. Androgen deficiency occurs in as a part of the aging process in the postmenopausal women, and lack of androgens impairs the secretion of meibum. So when this secretion of meibum is reduced, the meibum that is already present inside the meibomian glands and in the meibomian ducts, it becomes thick. The thick lipids in it, they link together. There is increase in the osmolarity of the meibum secretion, and that also incites a chemical inflammation, and that chemical inflammation disrupts the long chain fatty acids. They split up into free fatty acids, and these free fatty acids then cause a chemical inflammation of the ocular surface. As those fatty esters and the free fatty acids, they get inflamed, they clog the opening of the meibomian orifices, and further meibum cannot come out. Also the the meibum becomes thick and cheesy, as is seen in the picture, which can be expressed like a toothpaste. So the meibum, if it is not available to line the tear film, the evaporative loss increases and the cornea becomes dry. In fact, the whole ocular surface becomes dry. The aqueous layer is the main layer of the tear film, and it supplies oxygen to the cornea. As there are no vascular supply to the cornea, the vessels stop short at the limbus. So oxygen is supplied from the atmosphere, is supplied via the aqueous to the whole ocular surface. The aqueous layer, it polishes the cornea, then it contains immunoglobulins, enzymes, cytokines that have an antimicrobial property. Excess of tears, they wash away any debris that land on the ocular surface, and the aqueous layer has the important epidermal growth factors that help in the replacement of corneal epithelial cells if they are damaged. There are the perilimbal, in the whole perilimbal area, there are stem cells, and they are continually replacing and regenerating the corneal epithelium. The accessory lacrimal glands are responsible for a slow, continuous production of aqueous, which is called the basal secretion, and that occurs in response to impulses generated from the ocular surface as soon as a dry spot appears on the cornea. On the other hand, the main lacrimal gland outpours its secretion in huge amounts in response to strong reflex stimuli, as in crying, laughing, or eating a spicy food, or in response to emotions. But it's the basal secretion which is mainly keeping and maintaining the tear meniscus and the precorneal tear film. And it is this basal secretion which is assessed by the Schirmer 1 test with the anesthetic eye drops. So the third layer of the tear film is the mucin layer, which is produced by the goblet cells of mainly the conjunctiva but also the cornea, and that mucin makes the hydrophobic corneal epithelium hydrophilic. These mucins are present as free molecules inside the aqueous layer of the tear film, and they act as cleanup proteins. They pick up the dirt, debris, or any pathogen that lands onto the ocular surface, they engulf these bacteria as well as any debris, coats them, and then with the outpouring of the aqueous component of the tear film, the whole bug covered over by the mucins is washed out of the eye. They prevent the adherence of pathogens onto the cornea. If the viruses or the bacteria, they cannot attach to the corneal epithelium by virtue of the tear film, they will not gain entry into the cornea and they will be unable to cause disease. The mucin layer is reduced in vitamin E deficiency, in chemical burns, or in disease, and it can be detected by the corneal staining either by fluorescein or by vital stains like lissamine green and rose bengal. The next important topic is the assessment of the ocular surface. As I said, there are 6 components which constitute the ocular surface. So we have to assess all of them separately to exactly know what is the underlying cause, because the problem from one component spreads to involve the remaining as well. Patients mostly present with ocular discomfort, a moist, watery eye, itching, redness, discharge, glare, particularly while driving, floaters, blurring of vision, headaches, asthenopia, and that can aggravate as extremely painful eyes as well as photophobia, and then that photophobia can worsen to cause severe blepharospasm. A detailed medical history of autoimmune diseases like rheumatoid arthritis, SLE, Sjogren's syndrome, and then diabetes. They are important causes of dry eyes. They not only affect the production of aqueous but also of meibomian gland secretion in these patients. Similarly, history of systemic medications like diuretics, antihistamines, oral antihistamines are particularly known to reduce the production of aqueous, beta blockers. So they all need to be mentioned in notes, clinical notes, and stopped if possible. The Ocular Surface Disease Index score is a 12-item scale for the assessment of symptoms related to dry eye disease and their effect on the quality of vision. It comprises of 12 questions which the patient is asked at the first visit, and then to assess the at the first visit to assess the severity of the disease, and then at each follow-up visit to analyze whether the therapy that the clinician has instituted is causing any improvement or not. So it is a very important score and it has to be noted at each visit. Assessment of the general appearance of the patient and particularly the face is very important. The general appearance needs to be noted with regards to a systemic disease like rheumatoid arthritis affecting many joints, then thyroid eye disease in which the eye will be proptosed or there will be lid retraction, and that results in or precipitates or even aggravates the evaporative loss of tears from the eye. Then particularly note should be made about brow droop, then facial palsy that affects the functioning of the lacrimal pump mechanism, and the The ectropion, which is produced in a facial palsy, will prevent the spread of tear film over the cornea. While the patient is sitting on the slit lamp, a particular note should be made of the completeness or incompleteness of a blink. In a complete blink, both eyelids should be completely closed without any gaps. A complete closure of both the lids on blinking will ensure that the upper lid will pick up the tear meniscus from the lower lid and spread it uniformly over the cornea. While the patient is on the slit lamp, a systematic assessment is made of the not only the lower lid margin, which should be completely opposed to the globe, but also of the position of eyelashes, which should be drawn outwards. There shouldn't be any distichiasis, which indicates aberrant eyelashes growing out of the meibomian gland orifices. Then you need to note any frothing at the lid margins, which indicates bacterial inflammation of the meibum. Then any scarring, redness, or swelling of the eyelid margins, which indicates a chronic meibomian gland disease. Meibomian orifices should be looked at regarding their patency, or they are clogged with thick meibum, or they are absent and there is a notch on the lid in place of a meibomian gland orifice. The quality of meibum present at the lid margins need to be looked at. It should normally be clear and liquid at body temperature. Then the meibum should be expressed individually from each gland by gentle pressure on the lid margin, and the meibomian gland expressibility score should be mentioned in the notes, that how much glands which were expressed, and from out of these how many were appearing normal. Meibography can be done by a vinosity, but also by a pen torch, and looking at the uh, number of meibomian glands which can be visualized through the lids. The tear meniscus height is an important index of the severity of a dry eye, and it should be measured, and its clarity should be noted that it is without any debris. Then the tear film breakup time, corneal or conjunctival staining, Schirmer's test, they are all given in detail in the remaining sections of the chronicle. Tear osmolarity is very important, and it can be measured by osmolarity meters. The tear ferning test, it indicates the level of solutes in the tear film. And lastly, the cornea is assessed regarding its clarity, the presence of pannus, of frank vascularization, any opacities, uh, then epithelial defects, or keratinized spots. This slide shows some other tests that can be done for mucin and for lipid component in the meibum. Matrix metalloproteinases 9, they can be assessed in lab, and they are indicators of dry eye. And then the tear film turnover rate by a fluorophotometry. The tear film breakup time detects the excess evaporation of aqueous or reduced or poor quality of meibum. When you instill a drop of fluorescein, the normal fluorescence from one blink to the next is indicative of the tear film breakup time and is more than 10 seconds normally, and it shows no evaporative loss. However, if there is excessive evaporation of tears, then the meibum will mix up with the remaining tear film and will show up as dark islands in between the blinks. And if it is less than 10 seconds, it is considered as abnormal and indicates an excess evaporation of aqueous. Then the extent and pattern of corneal staining, that is important to be noted in cases of meibomitis where there is an irritant meibum which irritates, or the toxic meibum which is produced, especially the free fatty acids in it. They irritate the lower part of the ocular surface and causes staining of the cornea and the conjunctiva at the inferior limbus. However, in evaporative loss of aqueous, there is central corneal and conjunctival staining, and it may result in sterile central corneal epithelial defect, and this is due to the central part of the cornea being most exposed to the environment. The next slide, this shows the incomplete blinking that affects the spread of tear film and its drainage by uh, a faulty lacrimal pump mechanism. Similarly, a cicatricial ectropion will have the same effect. So to summarize, these are all the tests that need to be done for the assessment of an ocular surface. I hope the significance of the ocular surface and its assessment would be clear to everyone. And after listening to this lecture, you can go on to the next lecture of dry eyes. Thank you very much for your patience. And if any questions or comments, you can post it at the end of this video. Thanks very much.